So I will next call upon stage our next speaker, Dr. Chaitra Jayadev, Head Vitreoretinal Services, Narayana, Nethralaya, Bangalore. She will be talking about current perspectives in the choice of tamponade and postoperative positioning in macular hole surgery.
Good morning, everyone. I'd like to thank Dr. Dhanashree and the entire SN team for this opportunity. I think there's always a debatable question as to which tamponade to use and which postoperative position for how long. I think that's a very often debated topic, and the very first time mention of tamponade was even made by Kelly and Wendell in the study in 1991. So first I will cover the choice of tamponade, which one to use and which not, whether we actually need tamponade or not. So we know the different hole closure mechanisms. The tamponade agent basically spans the hole. It prevents trans-hole fluid flow from the vitreous to the cavity and therefore allows RP-mediated SRF removal. Next would be that it creates an interfacial surface tension between the retinal edges and actually acts to pull the edges of the hole together. So that's one other way that it helps. And the third way that tamponade helps is that it forms a surface, much like how we are expecting the ILM flap to allow glial cell migration between the retinal edges. So this is a scaffold much like our ILM flap. So with these mechanisms, we also know, and we spoke about it in the morning session, as to how we've heard of closure of macular hole with just spontaneous vitreous separation, and this is one particular case where you can see that there is hole closure with just separation. And we also know that ochriplasmin can give rise to hole closure in a couple of cases. I mean, it's not very useful in all cases, but in some. This is an image that I picked up from literature where they've used ochriplasmin. So is tamponade really necessary for all holes? And from all the studies that I went through while preparing this talk, the key factor appears to be one, the size of the hole, less than or more than 400 microns, and then of course the chronicity. Longer, more than a year, definitely warrants both tamponade and positioning. So these are the different tamponading agents that we have based on the duration that they act. But there is really no consensus regarding their relative efficacy. We used to use long acting before, now we've gradually changed to medium acting, and short acting I think is what most of us are using now. So these are some studies that I found where they've compared SF6 with the C3, F8, 79 and 59 eyes. What they saw was in both these studies that SF6 achieved similar results with respect to visual acuity outcome, macular hole closure, cataract development, and also adverse events. This is another study where it compared it with C2, F6. This study also found similar results, and SF6 is absorbed faster, hence quicker visual rehabilitation. Now compared to air itself, the primary hole closure rates were 90 and 92% respectively, again very, very similar between SF6 and air. And this is silicone oil versus long acting gases. Here the primary hole closure rate was 65% with silicone oil and 91 with C3F8, and 83 and 87 rather similar in this particular study, but you can see that the number of eyes are all very small. So since there is a lot of ambiguity, I think this systematic review and meta-analysis is expected to throw some light. What this study looked at was 13 publications, including 2 RCTs. What they also finally found was there was no significant difference in the anatomic closure rates between SF6 or any of the other gases. In fact, they found in a sub-analysis higher closure rates with SF6. And also the visual acuity outcomes or the adverse events were not significantly different in any of these gases that were used. Next, coming to postoperative positioning. Why do you need postoperative positioning? Is because it's thought to aid closure by the gas bubble keeping the edges of the macular hole dry, preventing entry of fluid. It again provides a scaffold for glial cell proliferation. So what is more important actually is to relieve the tangential forces. So the buoyancy of the gas bubble, which is maximal at the apex, is thought to be actually less important if all the tangential forces have been removed. Surface tension covers the macular hole as long as the volume of the gas is sufficient, which is expected to be at least 2/3 or 3/4 of the vitreous cavity. And you know, when this quantity of gas is there in the eye, you don't even need a face down position. That much itself is adequate to create a scaffold or a tamponading effect. The last thing is the precise time period that gas is needed to result in hole closure is really unknown. Of course, there are some OCT studies which I will show you, which shows early closure. So these are different positions that we've asked our patients to adopt, but we know that it is difficult because it is uncomfortable in the elderly. It's associated with back pain, sinusitis, ulnar nerve palsies. It's not feasible for all, especially somebody who's even, going to be undergoing an immediate surgery of some other, systemic issues that they have. They won't be able to do it. And studies using OCT in the immediate postoperative period has shown that it occurs very, very early, the closure, so much so as even within 24 hours in some cases. So these are different studies of 150, 69 and 30 eyes. What this Cochrane review saw was that they had different protocols with respect to positioning randomization. Two of these studies found that there was a significant benefit only when the diameter of the hole was more than 400 microns. And they said that there was no significant effect on successful hole closure when it was less than 400 microns in size. So this is another review which saw face down position versus others. This was 640 patients, a rather a large number. Again, they saw cutoff of 400. What they saw was that the significant effect of face down positioning was again only when it was 400, and they said at least for 5 days for larger holes. So that again goes to say that you don't need very long term, which means again the tamponading agent required is very less. This is a Retina paper which compared prospectively between face down and non-face down position. This was 80 eyes of 80 consecutive patients. They did ILM peeling and gas tamponade in all these patients. 40 patients were given face down position for 3 days, and the others were not advised face down positioning. They looked at the OCT at 1, 2, 3 days and 2 weeks, 1 month and 3 months. And then they compared the macular hole closure and the change in visual acuity. So here you see in day 1 itself, with or without positioning, 3/4 of the macular holes were closed. Day 2 saw a higher closure rate, and the results were unchanged at day 3. So their recommendation is postoperative prone positioning seems to be unnecessary for all macular hole repair procedures. They again recommend it only for larger holes. So this is one study that I found that compared both positioning and the tamponade, and they found that ILM peeling without the use of gas tamponade or positioning can achieve closure in small macular holes. So either of them are required. So once this topic was given to me for presentation, I actually went back and looked at all the OCTs that we have of patients who undergone macular hole, which we have taken in the immediate post-op period. So this is day 1. This patient was not given any tamponade because the patient was not for it, said I'm going to be traveling. So because no tamponade, no positioning, this is day 1. I'm sure it's going to get better. I don't have the follow-up images. This is again another patient which we have taken without any tamponade, and this is about I think 3 or 4 days post-op. I think probably we left with air, but then even that was absorbed at this point of time. This is also another similar case, and the next 3 cases I have are with gas. You can even see in the post-op image, you can see the gas there. These are all images that have been taken within 1 week of surgery, and you can see closure of the hole here. Again, you can see the gas bubble still in situ. These are 3 cases with SF6. So to conclude, before I actually give the conclusion, I am still using gas and I am still advising tamponade, but maybe I might be a little less aggressive after this. There is a relationship between the 2 choices with respect to gas choice and positioning. The longer acting, we probably be advising longer positioning. Do we have a consensus? This was a WhatsApp survey Dr. Atul had put up on one of the groups. Most of them are still using C3F8, and most of them are still advising 7 days or more of positioning. So smaller holes, shorter acting. When you're not giving face down positioning, use air. 5 days for larger holes, and of course patient centric plan for whatever you want to advise for your patient. Thank you so much.